Good morning, everyone. I'm Derek. I'm a PGY2. I'm going to change things up from a lot of the toxicology talks we've been having this morning and spend a little bit of time in an admin talk talking about physician scheduling and shift models. Before we move on, I'd like to just thank the admin talks team, Dr. Che, Yusuf, Gibson, Solger, and Xiao for their timely and very helpful feedback in helping me create this talk on a topic that I did not know too much about prior to getting into this. So just going over a quick outline today, we're going to go over the ASAP policy statement on shift work. And then we're going to shift over to talking about shift models and considerations, building a schedule, some examples of schedules that are already made, and then finally some takeaways. So even before we discuss the ASAP policy statement, I want to talk about why is this topic important? So over the past 20 to 30 years, there have been numerous reported incidents and articles published about falling asleep at the wheel among healthcare workers, especially when driving home after working an overnight shift. Because hospitals need to be staffed at night, many specialties have to grapple with the difficulties of staffing their hospital at night while considering things such as provider safety, getting home, and wellness and burnout. Because of the nature of shift work in the emergency department, ACEP released a policy statement highlighting the areas it found to be most important when preparing a schedule, including addressing circadian rhythms and shift work. Right here, you can see they highlighted well-being as adversely affected by constantly rotating shifts. This statement was first approved in 1994 and most recently updated in 2017. It highlights well-being and the important reasons why an important reason why some physicians choose to leave emergency medicine. ASAP endorses that shifts should be scheduled with circadian principles in mind, and we'll get into what that means. Also, ASAP states that shifts should be no longer than 12 hours and that regular periods of at least 24 hours off work is very important. ASAP recommends rotating from day to evening to night shifts as much as possible. And this is what we're talking about when we talk about circadian principles. And then night shift worker schedules must be designed to provide anchor sleep periods, which are hours during the day that are the same day by day that physicians are able to rest either before or after a shift. When making a master schedule, ED volume, patient acuity, and non-clinical responsibilities need to be taken into account. And then finally, the last ASAP policy statement recommends that they should provide a place to sleep before driving home after night shifts. So moving on, now we're going to talk about different shift models and considerations. So anytime we talk about shift work, we talk about, a lot of us went into emergency medicine because we like to work from a set hour to set hour, hand off our work at the end, and then be able to go home and not have to deal with too much work after we leave. But there are also many challenges of shift work. A lot of studies have shown that there's an increased cardiovascular mortality, increased fatigue, divorce rate, higher rates of substance use and depression from shift work. Also note some increased accidents from working night shifts. Outside of the ED, notable accidents in the past include the Exxon Valdez oil spill, also the 3 Mile Island accident, which was a partial nuclear shutdown or meltdown, and the Bhopal chemical plant explosion, all occurred during night shifts when people had been overworked and tired. Circadian rhythms are also a big topic when it comes to shift work. Circadian rhythms, as we all know, are bodily rhythms that vary throughout the day in periodic fashion. There's both the endogenous component, which includes the internal clock in the suprachiasmatic nucleus of the hypothalamus, and then also exogenous components, which are like the light and dark cycles that every 24 hours. Temperature is also a big part of circadian rhythms. For day workers, our temperature usually peaks at around 4 p.m. when we're most active, and also dips around 4 a.m. when we're sleeping. Working at night often pits our endogenous against our exogenous components. And then uh, some studies have shown that our bodies actually abide by more of a 25-hour day schedule, even though each day is 24 hours. This is the reason why we're able to sometimes stay up later and then have an easier time waking up later the next day. But it for if like during the holidays, if we stay up late, and even if we sleep early the next day before work, we still have a hard time getting up early. Shows that our bodies often go by a 25-hour schedule, which is why circadian scheduling is which is the basis for supporting circadian scheduling. Sleep is also important when we're considering shift work. Uh, Studies have shown that very long and very short sleepers have increased mortality. I think a lot of sleep study have settled on 7.5 hours as the recommended amount of sleep to get per night, high quality sleep for optimal health in adults. Um, and there are multiple stages in sleep. The ones I want to highlight here are stage 3 and 4, which are considered the slow wave sleeps. And this is thought to be the time and the most important time for our bodies to repair itself. As we go through the night, slow wave sleep decreases and the REM sleep increases. A lot of us take caffeine during our shifts. Caffeine actually affects our cycles. It causes us to shift between different stages of sleep more rapidly. And alcohol is also known to decrease the amount of REM sleep that we get. Finally, daytime sleep after night shifts is often less in quality than a normal night of sleep. Oftentimes, we sleep 1.5 to 2 hour times shorter than the normal nocturnal cycle. This can lead to problems of alertness during night shifts, especially when we're adjusting. So when deciding on a schedule to implement, the emergency medicine physician group must first consider the census, the acuity, the group size, and group preferences. Uh, and then decisions need to be made on multiple factors and variables, including the day-to-day shifts models, how night shifts will be staffed, and how long each shift will be. And we're going to go through each of these in a short discussion. So the traditional shift model is just 8-hour rotating shifts. This is the one that we see most often from 7 a.m. to 3 p.m., 3 p.m. to 11 p.m., and then 11 p.m. to 7 a.m. With increased staffing from 12 to 8 or 11 to 7, given the busy afternoons that we often have in the emergency department. This is the most common shift model. Some other ones that I want to talk about are some more non-traditional ones that have been tried and are definitely more rare. One example is the 2 a.m. to 10 a.m. shift, then 10 a.m. to 6 p.m. and 6 p.m. to 2 a.m. The thought process behind the shift model is to get so that each person is able to get some sleep during regular nighttime hours. Each one of these shifts allows for a little bit of nighttime sleep. Another shift model shortens the less desirable night shifts. So a 10-hour day shift, an 8-hour evening shift, and a 6-hour night shift. And then the last model kind of combines multiple aspects of the previous ones. A non-traditional model, an 8-hour 7 to 3 shift, and then a 9-hour 3 to 12 a.m. shift, combined with a 6 to 2 a.m. 8-hour shift that overlaps with the night shift. As you can see here, the night shift is shortened, but there's also increased evening coverage to help for patients, especially when there's more at night. Uh, Having nocturnists or night shift doctors cover the majority of nights is a really helpful factor for any overall EM group. From a circadian perspective, the goal is to never rotate shifts, and having dedicated night shift doctors helps prevent non-night shift physicians specifically from rotating too much on nights. So some night shift models, there's two main ones that I could find. The first one is called block nights. This is essentially when you have when a non-night shift physician has a long block of nights. So an easy example of this would be if there is a physician group of 6, you could split the year into 2-month segments, and then each physician would take 2 months straight of nights, with obvious like days off in between where the other physicians in the group would cover. In this way, each physician would have 1 block per year where they're doing nights, and then appropriate time to adjust their circadian rhythm to the night shifts. A lot of people complain that this is very difficult for family time, especially if you get the 2 months during holidays and things like that. The other more common night shift model is isolated nights. And this is when you have 1 to 2 night shifts at a time. And the goal is to never reset your circadian rhythm here. And then also working 4 to 7 nights in a row is usually condemned because this often causes inappropriate phasing and adjustment between shifts. Once you're starting to adjust to your night shifts, you get abruptly shifted back to your day shifts, and repeated periods of this over time can lead to burnout. And the final discussion we'll have is conversation about shift lengths. Usually, for most groups, there's always a range from 8-hour shifts to 12-hour shifts. 8-hour shifts work better for high acuity settings with increased census of patients, and it's easier to apply circadian scheduling. For 12-hour shifts, this is often in more low acuity settings with a lower census, with time to sleep during night shifts occasionally. Some people really enjoy these more because you get an extra 1/3 of days off from hospital responsibilities. And for those with long commutes, it makes it easier because you don't have to commute as much. Next, we're going to talk about how to build a schedule and the ways that we go about that. So first question is, who should make these schedules? So discussion is always had about whether a physician should make it or a clerical admin scheduler. For a physician, the pros are that it doesn't require that much training. An EM doctor is already um, uh, knowledgeable about the rules, the appropriate sleep cycles, and they're already invested in creative and effective schedule. However, this can often take away from patient care. There's always the increased chance for bias in these schedules and a potential for burnout with all the other admin tasks that we're required to do. For a clerical admin scheduler, this could potentially help with cost savings. And in theory, the schedule becomes more objective with the third party helping to make the schedule. More time can be dedicated to scheduling, but it's definitely a steep learning curve, especially for people not in emergency medicine or people who are outside of medicine completely. And then who's included in the schedule? So full-time employees, which include us, physicians, mid-levels, and also part-time employees as well. I think those are pretty obvious what those mean. We also have locums and per diem. So locums providers are temporary. It's the temporary position used to cover for short-term absences and to fill in gaps in staffing or provide additional support during busy periods. This can last from several days to months and span multiple locations. But these are very temporary roles. The other model of staffing is having per diem shifts, working on a day-by-day basis. This is used to fill daily staffing needs and to provide coverage for shifts that are often difficult to staff. These are very highly flexible and allows professionals to choose their shifts based on their availability. Different scheduling models include acyclic scheduling. This is the most common one. The easiest way to describe this one is you make the schedule from scratch every month. Um, the pros of this is it allows for vacations, requests, preferences, all to be considered and accounted for. But this can be very time consuming. One of the studies I took a look at estimated that in a physician group, a 22-person physician group, in order to make a 3-month schedule, it could require as much as 40 hours to put it all together. And then the quality of the schedule depends on the person creating it. Another example is a cyclic schedule without rotation. This one's not used very often because it's very rigid. Each physician in this group would constantly repeat the same shift pattern with a goal of not having a multiple of 7 days in the schedule. I'll show you in one slide, but having a multiple of 7 days makes things more equitable and more simple. But oftentimes weekends are broken up and it doesn't really consider requests or personal preferences. So in this slide, you can the D1 to D13 shows a 13-day rotation, and then MD1 to MD8 shows 8 physicians in the group. So essentially, MD1 would complete that entire 13-day schedule, and then they would just start this rotation again. Because it's 13 days, the start date for the next rotation will not be the same start date for the first rotation, like the day of the week, making for more equitable schedule and less desirable shifts. One other type of scheduling is a cyclic schedule with rotation. Every physician in this type of schedule would follow the same pattern with different equally spaced starting points. Um, the pros of this are that it's equitable and it's relatively simpler, but it's difficult to accommodate preferences and special requests. I'll explain what that means in this next slide. So this schedule, you can see schedule A through G, and ideally each one of these schedules would be taken up by one physician. So schedule A, let's say one physician's in schedule A, they would do the schedule for this week, and then they would probably shift to schedule B the week after, and then schedule C the week after. And then all the other physicians would also rotate through all of them. So over the course of 7 weeks, um, everyone will have rotated through this, each one of these different shift schedules. One study I saw talked about self-scheduling, where faculty members are able to take control of their own schedule. This was based out of University of Connecticut, scheduling 3-month-long quarterly blocks. So the way that this works is that the dedicated night attendings there would pick up their shifts first. So they chose the nights that they were going to work and to fill their full-time or part-time requirement. And then the schedule was passed on to the rest of the positions in the group. Then each physician, there's a list of orders, an order like of physicians, and then each physician has a chance to schedule 1/3 of their shifts wherever they want in the open slots. Once they schedule 1/3 of their shifts, they would pass it on to the next physician to schedule 1/3 of their shifts. Once every physician had their turn, you would go for another 3 turns, each time scheduling 1/3 of their shifts, and then 1/6 and 1/6. In this way, each physician had a good amount of control over what type of schedule they were able to build from themselves. And it's equitable because this list can change from quarter to quarter, for who gets to choose their shifts first. And finally, more recently, there have been increased use of computerized scheduling. It happens at the intersection between medicine, informatics, and operations. Different types of mathematical models can theoretically weigh different inputs and constraints, from preferences to fairness constraints, and iterate through a list of schedules until it finds the most optimal one if given enough computational time. All this graph is showing is a list of models over time. So each one of the columns is a different type of mathematical programming technique. And all I just want you guys to see is that since 1985 to now, there's been a lot more papers published on trying different computerized models and mathematical techniques to make schedules. Finally, I want to close with talking about some shift model examples that we may or may not be familiar with. The first one is with this hospital, Adams County Regional Medical Center. It's a hospital that I rotated in medical school. It was a critical access hospital with either single or double coverage at all times, usually double coverage during the days. These physicians were often locums physicians, and they would work 12-hour shifts at a time, either 7 a.m. to 7 p.m. or 7 p.m. to 7 a.m. with occasional back-to-back shifts, which I thought was crazy. They would either work 7 p.m. to 7 p.m. the next day or 7 a.m. to 7 a.m. the next day. Also had the privilege of rotating at the VA this year. And from what I've seen, they get around 20 to 40 patients daily. And it's a specialized group of veterans. And they have an urgent care from 8 a.m. to 2 p.m., taking up all the ESI 4s and 5s. For these physicians, they work 10-hour shifts, and there's physician assistant staffing as well. Essentially, an attending comes in at 8, PA comes in at 10, and then another attending comes in at 12. And then sometimes another attending comes in at 2, depending on which day of the week it is. And then there's a single attending overnight from 10 p.m. to 8 a.m. Changing over to downstate, this hospital's resident and attending staffed with 8-hour shifts, staffing a main ED, a fast track, and a pediatric ED. This is more of a traditional model that we talked about earlier, 7 a.m. to 3 p.m., 3 p.m. to 11 p.m., and then 11 p.m. to 7 a.m. with the occasional swing shifts during the busy hours. And then Kings County is also similar in that way. It's a level 1 trauma center with resident and attending staffing with 8 to 12-hour shifts covering all the different areas that we know. There's the standard 7 to 3, 3 to 11, 11 to 7, and occasionally the 7 to 7 shifts for the OBS and certain other shifts. We also have additional swing and pivot shifts when things are busy to help move the patient care along. So just wrapping everything up, I want to talk about the ideal schedule. So an ideal schedule is individualized by hospital and group, and it has appropriate staffing for the patient flow, depending on the day of the week and the time of the day. It's equitable, and it maximizes physician preferences while also being fair, and it emphasizes circadian principles as well. And then also isolated nights instead of chunks of 4 to 7 or blocks of nights. My key takeaways, EM shift scheduling can affect long-term well-being. I think we all know that from the busy resident schedule that we work. So I think once we start looking for fellowships and jobs, I think it's important to consider the types of schedules that are being made, how the shifts are being oriented, whether they use circadian scheduling or not. Different scheduling needs are based on different individual hospitals. Emergency medicine doctors work in a wide variety of settings, from rural to very urban settings, and different schedule needs and models fit certain settings better. And then just be on the lookout for more computerized schedules coming up in the future that may be more fair, maybe less tasking for physicians that have to make a schedule. All right.